Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is limited cutaneous systemic sclerosis. So this is part of a two-part series on systemic sclerosis, which is an autoimmune connective tissue disorder. There are two different forms, limited cutaneous and diffuse cutaneous, and today's episode will be discussing the limited cutaneous form, and we hope to give you a bit more information about the difference between the two. So what is limited cutaneous systemic sclerosis, which from now on I will refer to as LCSS on the subsequent part of the video. So this is a connective tissue disease characterised with thickening and fibrosis of the skin, which is known as scleroderma. So you may hear it called that sometimes as well. It can also have wider organ involvement. This is a rare condition. The incidence is approximately 4 to 12 cases per million per year. It can affect any and all racial groups, and the female to male ratio is approximately 4 to 1. The clinical features of LCSS can traditionally be recalled using the acronym CREST. So this stands for calcinosis, which is characterised by calcium deposits usually found at the fingertips, and which can be quite painful and can ulcerate. Raynaud's, which you will know about from the previous video, and this is an initial complaint in about 70% of patients, so that's quite high, and can be associated with digital ulcerations. Esophageal dysmotility, so patients may report symptoms such as reflux, abdominal pain, even sometimes diarrhea and other abdominal symptoms. Sclerodactyly, which is thickening of the skin, and telangiectasia, which are small, often described as blood spots, which can occur in places such as the face and also the chest, for example. Skin thickening in LCSS is limited to the neck, the face, and distal to the elbows and knees, and this is why it's called the limited form. As we'll find out in the subsequent video, the diffuse form can affect any part of the body. There is an early edematous phase and a later indurated and hidebound phase when it becomes more progressive. Affected areas may be pigmented and can also lose hair. Limited cutaneous systemic sclerosis can also affect the kidneys, and in the case of LCSS, this is quite rare. It's known as a renal crisis, and this is characterised by a malignant hypertension, so really high blood pressure readings associated with rapid renal failure. However, in the limited form, pulmonary hypertension, which is also associated with systemic sclerosis as a whole, is more common, and patients may have fibrotic interstitial lung disease, which is contributing to this. Clinical features are quite wide-ranging. So as you can see, if you do, for example, suspect systemic sclerosis in a patient, for example, in PACES, there's several systems that you do need to examine and explore. So we've already talked about the skin and the lungs, for example. So looking at the musculoskeletal features, these patients can report arthralgias. 30% in fact have an erosive arthritis. They may also report a myositis, so muscle weakness and pain, as well as flexion deformities of the fingers due to the skin fibrosis that they're experiencing. In terms of gastrointestinal symptoms and signs, they may report impaired motility, which can be at any level of the gut, And this manifests as reflux, dysphagia, peptic strictures as well. And they can get symptoms of gastric dilatation. Bacterial overgrowth is not uncommon in these patients, which can lead to malabsorption, and steatorrhea and pseudo-obstructions can also occur as well. When investigating a patient in whom you suspect systemic sclerosis, it's important to do the usual blood tests that you would do when you're suspecting any connective tissue disease in someone. Looking at the more basic blood tests, you would of course do a full blood count, renal function, particularly important in people with systemic sclerosis, and liver function tests, particularly if you want to think about starting a new drug. Looking at their inflammatory markers, their ESR and CRP may be elevated. Overall, in all patients with systemic sclerosis, so this is looking at the limited and the diffuse form, rheumatoid factor can be positive in up to 30%, and ANA positivity is seen in 90%. In people with the limited form, anti-centromere antibodies are positive in 50 to 90% of patients, and as we said before, they are at greater risk of pulmonary artery hypertension. Anti-SCL70 antibodies, or anti-topoisomerase, can in rare cases be seen in limited forms of systemic sclerosis, and this is associated with a greater risk of progression of their interstitial lung disease. Usually SCL70 antibodies are seen in the diffuse form of the disease. Management of patients with systemic sclerosis really depends on the signs and symptoms that they're experiencing. So can, in milder cases, be supportive. So for example, using non-steroidal anti-inflammatories for arthralgia and pain, proton pump inhibitors or famotidine for gastric symptoms, and intermittent antibiotics, particularly if someone is experiencing symptoms of bacterial overgrowth in the small bowel. As we saw in a previous video, the management of Raynaud's does involve the use of gloves, may require vasodilators, for example, nifedipine. Sildenafil is a really important drug in these patients, particularly if they're experiencing digital ulceration or indeed pulmonary artery hypertension. And prostacyclin or iloprost infusions may be required for severe Raynaud's symptoms and digital ischemia. You can see our video on Raynaud's phenomenon in a previous video, just the one prior to this. The more complex management of these patients can involve the use of disease-modifying agents, and indeed patients do tend to be on at least one DMARD. However, it's difficult to stipulate exactly which one may be used in these patients due to the heterogeneity of the disease, and subspecialist advice is often required and should be sought, particularly in the use of a multidisciplinary team setting. So for example, as a rheumatologist, they may need to consider the opinion of respiratory colleagues, gastroenterology colleagues, depending on the symptoms that a person is experiencing. So it's important to manage individual symptoms and manifestations in that particular patient. Examples of DMARDs used for limited cutaneous systemic sclerosis include methotrexate, mycophenolate mofetil, and the more complex biologic DMARDs such as rituximab, cyclophosphamide, particularly in severe disease and in interstitial lung disease. So now let's do some questions. Question 1. A 30-year-old female presents to the rheumatologist with a history of new onset Raynaud's phenomenon, arthralgia, calcinosis on her digits and sclerodactyly. She is a smoker. Her GP has advised her to stop smoking and has previously prescribed her nifedipine for Raynaud's. Which other symptoms is she most likely to have in addition to the above? So we've got here a 30-year-old female, so she's a little bit on the older side for a primary Raynaud's phenomenon, you'll remember from the previous video. And she's got this new onset of Raynaud's phenomenon, as well as arthralgias, calcinosis and sclerodactyly. So she's clearly got some features that might make you think about the limited cutaneous form of systemic sclerosis. So in terms of other symptoms, our options are alopecia, mouth ulcers, an erythematous facial rash, esophageal reflux and erythema nodosum. Looking at the first three, you might remember that those features are usually more associated, typically, with lupus, and are not the sort of classic features that one might see in a pure limited cutaneous systemic sclerosis. Although if you do see these features, you might want to think about an overlap type of disease, which we will discuss in a future video. Looking at option E, erythema nodosum, this is not a classic skin feature that you would see in people with systemic sclerosis, and therefore we are left with option D, esophageal reflux, which you'll remember is part of the CREST acronym. Question 2, which antibody is most specific to limited cutaneous systemic sclerosis? So our options are ANA, anticentromere, rheumatoid factor, anti-SCL70, and antihistone. So actually, at least 4 of these antibodies may be seen in people with limited cutaneous systemic sclerosis, but the question is asking us which one is most specific, and the answer to that is anticentromere antibodies. ANA is usually positive in these patients, but is not specific. Rheumatoid factor may be seen, anti-SCL70 may sometimes be seen, but usually seen in the diffuse form, as we will find out in another video. And antihistone antibodies, you will remember, are classically associated with certain forms of drug-induced lupus. So thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss out on our next episode. Let us know in the comments which topics you'd like to hear from us in future, and we will see you for our next episode.